Speaker. This is Dr. John Favreau. He is a postdoctoral fellow in the Myocardial Regeneration Lab at Worcester Polytech Institute. He's also a research trainee in the Vascular Surgery Research Lab at Brigham and Women's Hospital. John, a great friend, received his doctorate in biomedical engineering from WPI, where his research concentrated on developing non-invasive and non-contact methods of measuring mechanical strain, particularly in cardiovascular tissues, of course, in vivo. John has a great record of publications, and happy to say that he was recently awarded the Sigma Side Dissertation of the Year Award at WPI. Now, without further ado, I'd like to introduce Dr. Favreau, and so that he can share with us his published and new findings. At this point, I will transfer the presentation rights to you, John. Right, John, let us know when you're ready.
Thank you, Mina. I want to thank Visual Sonics for giving me the opportunity to give this presentation, as well as thank everybody for attending this afternoon. So, like Mina said, I'm a postdoctoral fellow at Worcester Polytechnic Institute, but the work I'm presenting here today was performed in close collaboration with Keith Ozaki's lab over at Brigham and Women's Hospital. Before I get into our new science, I do want to touch on the clinical significance of our work. So, as many of you probably know, about a third of the deaths in the United States are caused by cardiovascular diseases. And coronary artery disease alone costs over $44 billion to treat in 2004. And the problem with treatments for these diseases is that many of the current interventions, such as stents or bypass grafts, often fail. Now, one of the major underlying causes of cardiovascular diseases is arteriosclerosis, and it's considered to be one of the biological processes that leads to many of these vascular diseases. And using the heart as an example, what happens during arteriosclerosis is over time, one of the vessels feeding an organ gradually becomes occluded by ingrowth of cells into the intimal layer of the blood vessel. And what can happen over time is those cells can completely occlude the blood vessel, preventing blood flow to the distal part of the organ and resulting in the case of the heart, a myocardial infarction. This can also happen in the peripheral vasculature as well, though. Now, a number of studies have shown that intimal hyperplasia, which is defined as the excessive growth of smooth muscle cells into the intimal layer of the blood vessel, is associated with arteriosclerosis and may underlie it. And also, a number of studies have shown that changes in arterial mechanical environment have been correlated with IH, suggesting that perhaps the mechanics that the arterial wall sees play a major role in the formation of intimal hyperplasia. So this leads us to think there's a real need to have a clear understanding of how changes in arterial mechanics lead to the biological process of IH, and therefore lead to arteriosclerosis and these cardiovascular diseases. Now, one of the most studied forces applied to the vascular wall is wall shear stress. And this is defined as the stress applied by the blood flowing over the endothelial surface of the blood vessel, causing basically a shear stress on the vessel wall. Now, a number of studies have shown that low shear stress correlates with IH, meaning regions that experience low shear stress have a higher likelihood of forming intimal hyperplasia than regions with higher shear stress. Another study has shown that increasing the blood flow in regions where IH is formed can actually cause progression of the intimal hyperplasia. At the same time, though, extremely high shear stress can also result in IH. And mean shear stress is not conserved throughout the entire vasculature, suggesting that there's not really a biological set point for shear stress that's maintained homeostatically. So this suggests to us, at least, that although shear stress definitely plays a clear role in the regulation of intimal hyperplasia, it is not the only force that regulates it. The other major force that's applied to the vasculature is wall tensile stress. And this is most simply defined as the force per unit area applied to the vessel wall. So just to point out, wall tensile stress is basically applied in 3 different directions to the vessel wall. Here I'm showing all three in this element of the vessel wall. First is longitudinal, which I'm showing in blue arrows, circumferential in orange arrows, and radial in purple arrows. Now, although all three of these stresses are applied to the wall during a cardiac cycle, by far the largest is the circumferential stress, and therefore that's what I'll focus on for the rest of this talk. And just to give a quick review of mechanics and the relationship between wall stress and the different forces on the wall, here I'm pulling up the Laplace equation for a thin-walled tube in the circumferential direction. And although this isn't an accurate way to actually measure the stress on the wall, it does give us an idea of the relationship between the different forces. So here, as you can see from this equation, if you increase pressure or increase the vessel radius, you get an increase in stress. Well, if you get an increase in thickness, you get a decrease in stress. So as I go through this presentation, I'll refer back to this to kind of explain why we expect certain things to happen. Also, a number of studies have looked at wall tensile stress. They've shown that the vascular wall adapts to changes in stress, which suggests that there may in fact be a homeostatic level of wall stress. Now, very closely related to wall stress is wall tensile strain. And this is basically how much the vascular wall is stretched from its zero stretch state to its current state. And a study has shown that wall strain varies very little throughout the arterial crease, suggesting that this may also have a biological set point. Now, it's very difficult to measure total wall strain in vivo because with the vessel wall always under some amount of pressure, it's not possible to actually know the state of the vessel with zero pressure. In this study, however, we're going to talk about oscillatory wall strain, which we define as the stretch of the vessel wall from diastole to systole. And the reason we're looking at this mechanical factor is because we can actually measure it in vivo in a living animal. Now, in order to measure these strains in the mouse, there are several difficulties that we come across that we're hoping to overcome when we're trying to find a way to actually make these measurements. Now, the mouse cardiovascular system has a very small size. Many of the vessels are less than 1 millimeter in diameter, and even the heart has only an inner diameter of about 3 to 4 millimeters. So this led us to a need to actually have a high temporal resolution, high spatial resolution because of the high heart rates in the mouse, and a non-invasive method for determining wall strains in these mouse models. And this is where we decided to start using the Visual Sonics Vivo 2100 system. So this is a previous study by another lab where they showed that basically looking at the mouse heart, they can measure strain in 3 different directions using different views of the heart. And using ultrasound speckle tracking, they can get these strains and look at cross-sections that are 3 to 4 millimeters in diameter. We actually recently published a study in 2012 where we actually looked at the aorta in the mouse. And the aortic diameter in a mouse is approximately 1 millimeter in diameter. We were able to show, to measure changes in strain in the aorta in a model of abdominal aortic aneurysm. In this study today, however, that I'm presenting, we're actually going to look at the carotid artery, which is even a little bit smaller than the aorta, looking at lumen diameters of 500 to 700 microns. Now, in order to test the relationship between vascular strains and intimal hyperplasia, we first need to have a model to actually measure strains, in a model that consistently produces intimal hyperplasia. So this model, that we call the focal stenosis model, was developed in collaboration with the Ozaki lab. And basically what we do is looking at the mouse carotid artery, we can see the common carotid artery and the external and internal carotid branches. What the Ozaki lab did is they basically took a 35 gauge blunt needle and they tied a suture around the needle and the vessel in a location about 1 millimeter from the bifurcation of the carotid. And then what they did is they pulled out this needle, leaving behind just the suture. And what they showed is this results in a 78% reduction in lumen diameter on average, and also a reduction in flow of about 85%. But most importantly, they showed that it consistently produces intimal hyperplasia in this region proximal to the stenosis. Now, to look at this histologically, here I'm going to present a Masson's trichrome of first pre-op, so this would be a baseline vessel. And as you can see, shown in red here is the smooth muscle cells of the medial layer of the vessel, and in green is the adventitial layer. You can see there's really not much ingrowth. There's a consistent vessel wall thickness around the vessel. Looking at day 28 in our model, however, you see a significant change in the morphology of the blood vessel. Here we've actually highlighted the internal elastic lamina in yellow to give you an idea of where the initial inner wall of the vessel is and where it is after the formation of intimal hyperplasia. As you can clearly see, inside of this yellow line, there's a significant amount of cellular growth and material inside of the internal elastic lamina that we don't see in the baseline vessel. So looking at our focal stenosis model of intimal hyperplasia, we first began by looking at longitudinal views. So basically looking at the vessel as it looks in this diagram. I'm just going to wait a second while everybody's video loads before I start playing it. Okay. Looks like a few people are falling behind here, but basically here, what I'm going to show you is a color Doppler image of the longitudinal section of the blood vessel. And as you can see, it should basically line up with this picture. Here in the center, you can see our suture, basically, where you lose view of the common carotid artery. And then beyond, you can see that we can actually see the blood flowing past that suture, meaning showing clearly that we do not actually fully occlude the vessel. Now, using the Vevovasc system, we're actually able to measure the circumferential strains I talked about. So here on the left, you can see something that many of you are probably familiar with, a mouse in the supine position under anesthesia with a ultrasound probe. And what we do basically is lower this probe down over the carotid artery. And with that, we're able to visualize a cross-section of the artery and measure the strains using the Vevovasc system. And here you can see just one video of the visual sonic system actually tracking the vessel wall over several heartbeats. So in order to consistently identify spatial regions, which I'm going to talk about as we move through this presentation, we actually developed a method of finding a specific region on the carotid artery using ultrasound. And to do this, what we first did was we used ultrasound to identify the target carotid artery in the longitudinal view. As you can see here, we can see our suture in this ultrasound image. Over here would be the common carotid artery, and here you can see the carotid bifurcation. And so we would then center the probe on the tip of the bifurcation and then rotate the probe to produce a cross-sectional view. So essentially, imagine that this is the probe looking at a longitudinal view. If we rotate the probe 90 degrees, we're able to see a cross-section right at the tip of that bifurcation. Now, since the mouse is on a micrometer stage, from there we're able to easily just move the mouse with respect to the ultrasound probe, and thus we can produce a cross-sectional view of the blood vessel at a specific location at a known distance from the bifurcation. And so when I talk about measuring different distances from the bifurcation through the rest of this talk, this is how we're accomplishing that. Now, to actually measure wall strain, we used a combination of Vevovasc's internal tracking algorithms and then exported it to a custom MATLAB code where we actually computed strains. And so looking at the Vevo window, we would choose the region of interest in the ultrasound machine, and then we would actually export this area curve over time across several cardiac cycles and import that into MATLAB. From this, we would basically assume that the vessel had a circular cross-section, which is a pretty reasonable assumption based on what we've seen, and we would calculate the oscillatory wall strain, basically the strain from this diastolic point to the systolic point for each cardiac cycle using the formula for green strain. And then from that, we would output the mean oscillatory wall strain. And once again, using diastole as a zero strain state, we'd average that across 5 cardiac cycles to give us a oscillatory wall strain value for a particular region of the blood vessel. Now, with these tools in mind, we were able to develop a study that had 3 different objectives. So our first objective was to determine what relationship exists between mechanical strain and pathological wall remodeling. Our second objective was to correlate early changes in strain with IH formation. And finally, our third objective was to determine how early intimal hyperplasia occurs and determine to get a better idea of what the underlying cause of strain reductions is. So first, starting with objective 1, this part of the study is actually already published. It's in press now in the Journal of Vascular Surgery. And what we did in this first objective is we took 10 mice and we created the focal stenosis model in them. But before that, we took pre-op measurements of circumferential strain in several regions. And then also at post-op day 27, we measured strains in the same exact regions. Then at post-op day 28, we actually sacrificed the animals and stained the blood vessels for Masson's trichrome to actually quantify the intimal thickness. So a little more detail about the study. At this point in our research, we actually felt it was important to look at several different regions. But first, here you can see on the left common carotid artery, we create the focal stenosis, while on the right common carotid artery, we leave it untouched. And so this was in order to have a contralateral control artery that we can look at separately to see if the changes are happening globally in the animal or just on the left side. And so we assessed strain and histologically at day 28 in 3 spatial regions on each artery. And these are measured 2, 3, and 4 millimeters from the carotid bifurcation. So looking at another longitudinal image of the vessel with the focal stenosis right here, we basically, at pre-op and day 27, we measured strains in these 3 spatial regions. And then at day 28, when we sacrificed the animals, we went ahead and processed the tissues for trichrome and measured the intimal thickness at the day 28 time point. So what we found in the study was that, first of all, we get a significant formation of intimal hyperplasia on the left side in pretty much all of the animals. And so here, shown in red, is the intimal thickness on the left common carotid artery, where we created the focal stenosis, and in blue, the intimal thickness on the right common carotid artery. And as is clearly seen, there is a statistical increase in the intimal thickness on the left side as compared to the right in all 3 spatial regions that we looked at. Additionally, though, looking at the wall strain values at pre-op in the darker colors and at day 28 in the lighter colors, we can see that there's a massive drop in strain from the pre-op value to the day 28 value in all 3 spatial regions on the left side, while there's virtually no change in strain on the right side. So what we took away from this data here, both the intimal thickness data and the circumferential strain data, is that there really is no statistical difference amongst the 3 spatial regions in the measure of intimal thickness or in the measure of wall strain. And so to analyze the data to try and determine the relationship between intimal thickness and wall strain, we plotted the strains in all of the regions we examined as a histogram. And so here you can see with strain on the x-axis, the majority of regions have very low strains of less than 0.1 at the day 27 time point. Well, 4 of them have higher strains at the day 27 time point. So we defined a strain cutoff at 0.1, and we evaluated the intimal thickness outcome of those regions with low strain versus those with high strain at the day 27 time point. What we found is that there appears to be a trend toward increased both wall thickness and intimal thickness in the regions that have lower strain at day 27 versus those with high strain at day 27. And although there is no statistical difference here, we expect that that may be because the vast majority of regions are in the low strain. So this led us to start thinking about what may be the underlying causes of these strain reductions we've seen. So since over 80% of the regions showed dramatic reduced strains at day 27, we wonder if we can determine what's causing these strains. So wall strain reduction from a mechanical standpoint could be a result of any combination of a few different factors. First of all, there could be a decrease in the pulse pressure. So if you have a decrease in the amount of pressure change from diastole to systole, then it's possible that the amount of strain the wall would also decrease. Although we did not assess this in this study, others have assessed it in a similar model of intimal hyperplasia, looking at regions proximal to a flow reduction. And they found no difference in strain in their model. Similarly, from a mechanical standpoint, since we are looking proximal to the focal stenosis, we don't really expect a change in pulse pressure. Another possible cause of strain reductions would be an increase in the wall thickness. And so in this day 28 study, we actually did show that there is an increase in wall thickness in the majority of these experimental arteries. So this is at least contributing to the decrease in strain we're seeing at day 28. The other possible cause of wall strain reduction would be a change in the wall mechanical properties. So if the stiffness of the wall is increasing, then the vessel would strain less under the same pressures. So this led us to question how these strains we're seeing progress temporally. Because if we have the majority of regions with low strains at day 27, perhaps at an earlier time point, we might have a wider range of strains that can give us a better idea of how this strain relates to the intimal hyperplasia. So this leads us into objective 2, which is also published in that same publication. So what I've shown you so far is that at pre-op, we have very high strains, about 26%. And then at post-op day 27, we see strains of about 7% and significant formation of intimal hyperplasia. But this leads us to question of what happens at a earlier time point, such as day 4. So the results I'm going to show you in this next section are actually for the same mice, but here we're going to add the strain results that we measured at day 4 into that. So first of all, I've already shown you this pre-op data and this day 27 data. So what I'm basically adding in is this middle bar in each group. And as you can see, surprisingly, to us at least, the strains are reduced on the left side by day 4, and they remain reduced at day 28. And this is surprising to us, especially my surgical colleagues, because they really don't expect there to be significant IH formation by the day 4 time point. Also, just to note that on the contralateral control side, we see no difference at the day 4 time point from either pre-op or day 27. Now, to give you a better look at the histology, looking at the right common carotid artery or the contralateral control, you see these arteries at day 28 look like the baseline artery I showed you at the beginning of the presentation, with fairly consistent wall thickness and no apparent growth into the intimal layer. On the left side, however, where we have the focal stenosis, once again, we've highlighted in yellow the internal elastic lamina. You can see that there is significant formation of intimal hyperplasia in pretty much all of the regions of the vessels that we examined. Now, looking at this from a more quantitative assessment, you can see that we do have statistically significant increases in intimal thickness and wall thickness in at least one region in all of these arteries at the day 28 time point compared to control. So just a quick summary of what I just showed you. There are no differences in strain or intimal thickness as a function of distance proximal to the focal stenosis. And we found that the strains are reduced by the day 4 time points. Now, bringing back this histogram that I showed you early, remember that this is strains measured at day 27, and basically just a histogram of the regions at each strain level. Looking at the day 4 data, you can see that there's a much wider spread in the data. And using the same cutoff, which actually happens to be the median of this data as well, we're able to have about 13 regions in each group to compare low strain versus high strain. So here, what we're doing is basically taking the strains that we measured at day 4 in these animals and stratifying them based on those with lower strains and those with high strains. And so this is a plot of the intimal thickness at day 28. So this was measured 3 weeks after the strain measurements were made in these same animals. So 3 weeks later, we see that those with low strains at day 4 went on to form significantly more intimal thickness and wall thickness, our measure of intimal hyperplasia, by the day 28 time point, which suggests that there may be a relationship with low early strains and the eventual histological outcome in these animals. And so just to summarize that a little more, 100% of the regions in the low strain group, the low strain at day 4 group, produced significant intimal hyperplasia by day 28. Well, only 30% of the regions with the high strain at day 4 went on to form intimal hyperplasia at day 28. And so to us, this led to really the big question of, does this intimal hyperplasia form by the day 4 time point? So is there actually an increase in wall thickness that is causing these reductions in mechanical strain at day 4, or could it be caused by some other factor? So to test this, now I'm going to move into some of our unpublished work. We actually decided to look at intimal hyperplasia in these animals at the day 4 post-op time point. So to summarize what we've shown so far, we have higher strains at pre-op, and then reduced strains by post-op day 4 that remain reduced by day 28. And at the day 28 time point, we also have significant intimal hyperplasia in the majority of regions. In the Objective 3 study, however, we're going to look at intimal hyperplasia formation at day 4. So once again, we're going to use the pre-op strain measurement and the day 4 strain measurement, and we're also going to look at an immediate post-op strain measurement. So here, basically, what we're doing is taking the animals from the operating room directly to the ultrasound machine to measure strains immediately after creation of focal stenosis. Also in this study, we included some sham controls to ensure that this is not just an effect of the surgery, and we will also be, once again, including the contralateral control data in those same 3 regions. So here I'm showing in green the sham control arteries, in blue the contralateral control arteries, and in red the experimental arteries. So first, looking at the 2 control arteries, we see that there is no statistical change from pre-op to immediately post-op to post-op day 4 in either of the control arteries. However, in the experimental group, we see that there is a significant reduction in strain at the post-op day 4 time point compared to both of the controls, as well as the experimental group at day 0 and at pre-op. And so the first thing we note from this is that these results match those from the animals in the early objectives, in that at day 4, we have a significant reduction in strain. Additionally, though, we found it interesting that the strain reductions occur before this post-op day 4 time point, but somewhere after immediately post-op. So this suggests that our focal stenosis isn't immediately creating a reduction in strain, but rather the animal is reacting biologically to the focal stenosis that over time results in the strain reduction. Now, just to view this data in a different way, here what I'm doing is showing a plot of each of the animals we looked at in this study in the sham control, contralateral control, and experimental groups, and where they lie as far as average strain measurements. And as you can see, at the pre-op time points and the post-op day 0 time point, pretty much all 3 groups are in about the same range with approximately the same spread of the data. However, at the day 4 time point, what we see is very interesting. We see that in the 2 control groups remain about the same as they were at the other 2 time points. In the experimental group, however, we get some animals that have strains in the same range as the control groups. Well, about half of the animals are reduced below the strain level of the control groups. This suggests to us that maybe some of the animals we're looking at are reacting more to the focal stenosis, getting greater reductions in strain compared to the other animals. Additionally, I just wanted to quickly touch on the fact that in this study, once again, we found no difference amongst the three spatial regions, so the 2 millimeter, 3 millimeter, and 4 millimeter proximal regions from the focal stenosis. There were no differences amongst the three regions at any of the time points. Now, looking at intimal hyperplasia outcome at day 4, first I'll present this histologically, and then I'll actually show a numerical measure of the intimal hyperplasia. Here, with the sham control, this time highlighted in green, we have the internal elastic lamina and the external elastic lamina. As you can see, it looks like the baseline vessel I presented at the beginning of the presentation with no significant growth within the internal elastic lamina. Similarly, in the contralateral control, we see the same trend toward basically no increase in intimal thickness, no change in intimal thickness from what a baseline artery would look like. And finally, even in the experimental animals, we actually observed no increased intimal thickness in any of the vessels that we looked at day 4, despite the fact that we do have these significant reductions in mechanical strain at this time point. Now, to quantify this, here first I'm going to show intimal thickness. As a reference, I put in the day 28 data from the previous objective. So this is the intimal thickness of the experimental arteries at day 28. And then here is a measure of the intimal thickness in the sham, contralateral, and day 4 experimental controls. As you can see, and also statistically, there is no difference amongst the three regions. And we see the same trends in wall thickness as well, where you see that there is a decrease in wall. There is less wall thickness in the 3-day 4 arteries as compared to the day 28 arteries. So because we saw these changes in strain, but no changes in gross histology, we decided to start looking at some factors that may actually cause the initiation of intimal hyperplasia at this day 4 time point. So here what I'm showing is a carotid artery in the experimental group, and in green we're showing myosin heavy chain, and in blue nuclei by Hosch dye. And then adding in CD31, a marker of endothelial cells, you can see that there appears to be a fairly consistent expression of CD31 around the luminal surface of the artery, which suggests that the endothelial layer may be intact. To take a closer look, though, what we noticed was that in some cases, there are spaces in the expression of CD31 at the arterial lumen, and this suggests to us that perhaps there are some breaks in the lumen. And so to look at this further, we also stained for CD45, a marker of leukocytes. Now, leukocytes have been shown previously to be one of the initiators of the process of intimal hyperplasia. So this suggests to us that perhaps the leukocytes are homing to the endothelial wall at this day 4 time point. And to give you a clearer view, I will pull out the myosin heavy chain stain. And here you can clearly see that the leukocytes in yellow are interrupting the endothelial layer as shown by the red stain. So in conclusion from this third objective, we showed that early strain reduction only occurs in about 50% of the animals by day 4. And the strain reductions do not occur as a direct result of the focal stenosis, in that we did not see a reduction at that post-op day 0 time point. Additionally, we did not see any intimal hyperplasia formation in any of these arteries by the day 4 time point. And so going back to the reasons I discussed earlier for why wall strain reduction, what can cause these reductions in wall strain, once again, we assume that there are no changes in pulse pressure looking at the proximal region of the vessel. And we also know that at the day 4 time point, we don't have an increase in wall thickness compared to controls. So this suggests that, from our data at least, that the changes in the wall strain are being caused by a direct change in the mechanical properties of the wall. So either the composition or the layout of the wall structure is changing to cause these reductions in strain. So overall, we've shown that we can non-invasively measure strains in the mouse blood vessel And we've shown that low wall strain occurs with increased intimal hyperplasia at the 1 month time point. Additionally, low wall strain at day 4 seems to correlate with intimal thickness at day 28, suggesting that wall strain could be a factor that is used to predict intimal thickness at day 28. Additionally, oscillatory wall strain is rapidly reduced between the post-op day 0 and day 4 time point, suggesting that some sort of biological process is occurring that is causing the reduction in strain. And finally, we showed that leukocytes are visible at the vessel wall at post-op day at 4 days post-op, suggesting that IH formation is preceded by the oscillatory wall strain reduction in our model. So we do acknowledge some limitations to this study, and first and foremost is the lack of internal pressure measurement. So in the future, we do aim to actually measure pressure in these vessels and demonstrate that there are no changes in them, but in this study, we were unable to do that. Additionally, in the future, we hope to quantitatively assess the cellular and molecular changes, such as cellular proliferation, and also to quantify leukocyte recruitment to the wall at the day 4 and day 28 time point. And finally, to discuss some work we're thinking about for the future, we hope to assess the structural changes in the mouse model. In particular, we're interested in looking at elastin and collagen content in the wall, because these are the major structural proteins that we think may play a role in the reductions of strain that we're measuring. Additionally, we hope to look at the effects of stenosis reversal to determine if regions that have low wall strain at the day 4 time point are actually basically committed to go on to form intimal hyperplasia at day 28. And to do this, what we aim to do is actually remove that suture we tied around the vessel at the day 4 time point and see if regions with low strain continue to form intimal hyperplasia. And finally, thinking more broadly into the aspect of the clinic, we do know that ultrasound imaging is commonly used in the clinic to assess vascular disease, and we believe that obviously very far in the future, if these relationships between low oscillatory wall strain and the formation of intimal hyperplasia stand in larger animals and in humans, that perhaps ultrasound strain measurements could be used to non-invasively assess the susceptibility of certain vessels to intimal hyperplasia and arteriosclerosis. And with that, I'd like to thank all the people that have contributed to this project. In particular, I need to thank my PI, Dr. Glenn Gaudet, as well as Dr. Keith Ozaki, in whose lab we did the majority of all of these surgeries, as well as all of the surgeons in the Ozaki lab who performed the microsurgeries for this project. Finally, we also need to thank the number of people that have provided ultrasound equipment for these studies, including Rongli Lau at the Brigham and Women's Hospital and Helene Langevin of the Osher Center at Brigham and Women's. And finally, Visual Sonics provided an ultrasound probe for some of these studies. Also, my funding sources are listed here, and with that, I will turn it over to Nina.
Hi, John. That's very good. Thank you very much. That was a very comprehensive and integrated presentation. I'm just going to take the presentation right from you as we proceed to questions. So please send your questions through. I have a couple of questions here. You can send the questions in the chat window. Just type it along, and I will take your questions in a couple of seconds. The very first question is with regards to the translational component. How do you propose this can be done on humans? And if you can speculate at this point, that'll be okay, John.
Okay, yeah, certainly it would be speculation at this point. But since ultrasound images are commonly taken in patients that are prone to vascular disease or who have vascular disease, it would be very easy to record videos such as the ones we use for this analysis and determine the strains in the actual arteries. And if, obviously this is very speculative, in that if this relationship stands in humans as well, where regions that have lower wall strain are more prone to form IH, then it would give surgeons or clinicians another tool to actually determine how susceptible a vessel may or may not be to intimal hyperplasia.
Right. Thanks, John. In your opinion, and from what you read, are there any clinical ways to assess vascular strain today?
I have seen, I believe it's been done with MRI in humans, but I wouldn't want you to quote me on that. So I am not sure if there are methods where it's used extensively in humans. I'm not aware of any where it's used for at least diagnosis at this point.
Right, awesome. There is a question with regards to your slide number 27. I'm just going to pull that up for the question. Apparently here you show the different regions and the oscillatory wall strain at day 4. Would you happen to have, the question is, was there one done at 28? And I think that's the data you showed earlier. But for day 28, you have the mean the wall thickness and intimal thickness. Would you have done the same for day 4? And is it because the mouse is not available to do that?
So you may not know the answer. Are we looking to know what the intimal thickness is as measured at day 4?
That's correct. So the histology is there for day 28. But in this graph, we don't see one for day 4. And what would be the reason for it?
So in a particular animal at least, we can't measure intimal thickness histologically at 2 different time points in the same animal. And although we did do a day 4 study with measuring histology at day 4, we did not see any significant intimal hyperplasia in the day 4 histology. So looking at the different levels of strain with respect to basically a 0 histological outcome wasn't something that we were going to present.
All right. I think this is your...
Yeah, if you, on this slide here.
Yeah. So here you actually show at day 4 that there is no histological evidence of intimal hyperplasia, but the vascular strain obviously does show as a biomarker, correct?
Correct. So basically at the day 4 time point, we saw actually that graph right there, virtually no intimal thickness differences between the 2 control arteries and the experimental artery, which suggests that, intimal hyperplasia is happening somewhere between day 4 and day 28, but at least the gross aspects, the actual formation of new cellular material inside the internal elastic lamina is not happening at this day 4 time point yet.
Awesome. Okay. There's also a question about the molecular component, and it's just a great segue to slide number 35. So here you look at I think the question is to clarify how you made the decision that the CD31s apologize. Maybe you can reiterate the conclusion of this slide.
So what we conclude from this slide is basically that, well, there's not much we can conclude from this slide at this point. It's more to show that we have started to find that there may be leukocyte recruitment at as early as the day 4 time point. Obviously, I didn't present any quantitative data showing that there's an increase in the number of CD45 positive cells in the experimental group, because that work is currently ongoing. So the conclusion is kind of open at this point as far as what we can pull from this. But what we did see is that there is clearly some amount of recruitment of leukocytes in the experimental arteries at day 4.
Very good. So there is a question here. Was there any correlation between lower pre-op strain and day 28 intimal hyperplasia formation, or maybe low pre-op strain correlating to even lower strains than other samples at day 4?
No. So we did actually look at if the regions that had low strain at day 4 also had lower strains at pre-op, but there was no correlation there.
Thank you, John. And I'll do one more question here. Did you consider using Doppler to assess residual gradient in the surgical site to correlate IH and degree of stimulus?
No, we have not considered that, but definitely something we'll think about in the future.
Awesome. All right. I will be taking more questions, and we will follow up with your questions. I will relay it to John and continue following up with those questions to you. We'll move on to some of our closing comments as I progress through these slides. Okay. Since we were on the topic of molecular imaging, I just want to bring to your attention that there was a publication recently looking at molecular imaging of the vasa vasorum in the carotid. And this is, as you can see here, it is by Dr. Decano in Dr. Herrera's lab. Here they are presenting the carotid. You saw the carotid micro-ultrasound image of the carotid as shown by John. See the same thing out here. What you're seeing in green are microbubbles in the 2 to 3 micron size, and that's showing the blood pool in this image here. But once you have it targeted to, in this case, DESPR, you see the pre-image and then you see the post-image, and that's generally plotted in a plot like this. And when you see the signal high and after a burst of the bubbles, you see it drop down, then you know there's an expression of the molecular target of interest. In contrary, if you're using an isotype, just like any histological evaluation, you see the pre and the post, but when you plot it, the signal before and after the burst of the bubbles are at the same intensity, micro-ultrasound intensity. So this is called contrast-enhanced ultrasound that can be used to evaluate or assess molecular targets that may be responsible for disease progression, including what John had mentioned. And I thought this would be a great segue for those who have a Vivo and who have access to doing what John has described today, can go on to the next level and address molecular imaging non-invasively. Also, I'd like to share with you guys a list of molecular imaging that has been done using micro-ultrasound as I described before, and also photoacoustics. This technology uses optical light and based on the absorber within the tissue, in this case in the carotid, it forms an acoustic pressure that can be digitized into an ultrasound signal, and that's what photoacoustics is here. This table shows on the very first column shows you the molecular targets that have been published and I think are relevant to this field of arterial occlusive disease. Also the different cell types that these targets were addressed to and the diseases in which these targets were investigated in. For those of you interested in advancing your research by using any of these targets, you can use the contrast agents listed out here that are compatible to investigate in vivo. Of course, we have also listed what method, imaging method, whether it be contrast-enhanced ultrasound or photoacoustics, that can be used in combination with these agents for you to address the molecular targets in the cell type or disease of interest. Right. Next steps. As we come close to the end of this webinar, I'd like you to remember the webinar questions will be relayed back to you, and we will connect John on the responses for these questions. If you have a Vivo, a 2100 or laser, or a 770, follow up with support at visualsonics.com. You can be asking us the questions about vascular strain, as John had talked about, using the Vevovasc software, or if you're interested in advancing your research using molecular imaging in vascular sites, vascular organs, talk to us, follow up with us on topics of contrast-enhanced ultrasound using the contrast agent micromarker, or on photoacoustic imaging using the Vivo laser. Of course, feel free to talk to us about molecular imaging bibliography. If you don't have a Vivo, let us know how we can support you. And in the meantime, as trained scientists, stay connected. You have the VSI University to better understand and train to image just like John did. Also, webinars will be ongoing every month. For those of you who are interested in speaking on this platform, on the webinar platform, just like John, please enter the Vivo Ambassador Program. All you have to do is email me with your abstract and how you have used the Vivo technology to advance your research. All right, and that brings me to an announcement. Webinars will resume in September, so we're not having any webinars in July and August. September will preview vascular imaging in the brain, so join us then. We'll have a technology update in October, and in November we'll be looking at vascular complications in diabetes and in cancer. That brings me to the end. A great webinar. John, thank you so much for that very interesting webinar and seminar on the updates in vascular strain. We would like to invite you at this point to the Vivo Ambassador Program. Feel free to accept it right here on air or by email.
Yes.
Thank you, John.
I'd be honored.
John is pursuing his career aspirations, so feel free to contact us to get in touch with him. In the meantime, I'd like to thank all of you for your attention, and we hope to see you soon in September. This is Meena Lakshman signing off. Bye for now.